today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Neera Ghaziuddin about improving current diagnosis and treatment of bipolar disorder, mixed depression, and other mood disorders in the pediatric population. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Ghaziuddin discuss the current research on treating and managing pediatric bipolar disorder.
Welcome back to another NEI podcast. This is Dr. Andy Cutler, Chief Medical Officer of NEI, and it's really a pleasure to be here today with Dr. Neera Ghaziuddin, who is going to be talking with us about mixed depression and bipolar disorder in the pediatric population. So, Neera, welcome.
Thank you. Thank you, Dr. Cutler.
I want to get started, just jump right in here. And this is obviously a topic that whenever we do educational events at NEI, we get so many questions about this. But at what age do symptoms typically begin to emerge for bipolar disorder in kids?
So the way we look at early onset bipolar disorder is people tend to look at it in two age groups. Mm-hmm. Before the age of 12 is generally referred to as very early onset bipolar illness, and then adolescent onset is considered as early onset. Mm-hmm. So very early onset bipolar symptoms are usually apparent by age 5.
Oh my, that's certainly early. I would imagine that the earlier the onset, the more genetically loaded the person is. Is there a correlation with genetics?
Yeah, you're absolutely right. Early onset and very early onset seems to be highly correlated with positive family history. Generally, these are families that the history will repeat itself, but they'll have other family members who have early onset illness. The illness tends to be more severe in nature, more recurrences, poor outcome, and more comorbid conditions.
Oh my. So that really brings out the importance of recognizing this early and ideally trying to get appropriate treatment instituted.
Absolutely.
So talking about that, what are some of the most common symptoms of mania that you would see in children?
The commonest symptoms are irritability and increased activity. Mm-hmm. Generally, people will try to look at symptoms of mania under 3 domains. Mm-hmm. One is obviously to look under the mood symptoms, and then look under behavior, cognition, and interpersonal behaviors. So the mood symptoms can be irritable, expansive, elevated. The behavior symptoms tend to be more agitation, hyperactivity, social disinhibition. Mm-hmm. The cognitive symptoms tend to be distractibility, increased activity, often accompanied by difficulty in task completion. And then interpersonal symptoms tend to be a disinhibited social seeking, and depending on the age of the youngster, there may be grandiosity, and there might be also some sexualized behaviors or increased interest in sex.
Yeah, I believe I had heard there was some research that showed that grandiosity and increased sexuality were sort of the most specific for mania, because obviously you can see irritability and distractibility with other conditions such as ADHD. That doesn't mean they're the most common, though.
Yes, you're absolutely right, Andy, that these are not common symptoms, but when you see them, they have a very high specificity. Mm-hmm. And also it depends on the age and the development of the child. So obviously a 6-year-old will display their grandiosity and increased interest in sexuality in a very different way compared to a 16-year-old.
Now, I believe that came from Barbara Geller's group at WashU. Am I correct on that?
It probably did, yes.
I think it was. Okay. I'm also wondering about psychotic symptoms. Is that something that you're going to see commonly with bipolar in younger children or adolescents?
Yeah, psychotic symptoms can be relatively common. They are usually mood congruent, and there's really a wide range of frequency that has been described. It can be as low as maybe 15 to 20%. Some studies have found a very high rate, but they are relatively common. And obviously, you want to label a psychotic symptom as psychosis only if it is present quite persistently. There is a continuity of symptoms. And that's actually true for most of the symptoms when you're assessing somebody with bipolar illness, that it's not a one-shot diagnostic evaluation, that symptoms are assessed over time. And that's definitely true for psychotic symptoms as well.
Yeah, as we know, there's many things that can cause psychotic symptoms. They're very nonspecific.
Yeah.
We've sort of been talking around this question that I'm about to ask you, but what are some of the reasons that it's so hard to diagnose bipolar in adolescents specifically?
So I think that there is a range of different symptoms. I think the one that kind of really stands out is that there's a lot of knowledge and literature that has been generated over the last 10 to 15 years. So there may be many clinicians who completed their training and went into practice prior to the accumulation of the current knowledge. So I think that's an important factor. The other thing is that there is a developmental twist to the presentation of illness. So the symptoms may present in a way where the manic or the hypomanic symptoms may not be very obvious. Comorbidity is another problem because of the high coexistence with ADHD, anxiety, eating disorder, and OCD. The symptoms may not be well defined or stand out. And I think lastly, I think stigma is a factor too.
Yeah, I'm sure you're right. And then, there's the issue in adolescence of adolescents are more dramatic, more erratic, more emotional. And that's part of adolescence, isn't it?
Right.
I used to think when I came out of training, bipolar disorder is easy to diagnose. You just follow the DSM criteria. But the farther along I go in my experience here, the harder it seems to be to diagnose.
That's so true, because I think that's true for a lot of psychiatry, that the trick is in the detail.
Would you help a clinician to recognize bipolar in the younger children versus the adolescents? How does it present differently in those two age groups?
I think the single factor that has been shown to have a high correlation with the onset of illness is a positive family history. So I would advise the clinician to be really alert about a positive family history. And the greater the number of relatives who are affected, including second-degree relatives, there seems to be an additive risk. But as we know, not everybody with positive family history will get bipolar illness. And the converse is true as well, that not everybody who gets bipolar illness has a positive family history. But definitely the familial aspect of the illness is very important. And then there are other symptoms that we can discuss. So sleep disturbance tends to be a common symptom and very often becomes apparent quite early on. So these might be youngsters who have a sleep disturbance, which is long-standing and severe. It's not a typical sleep disturbance that you see in an adult who has a fully formed illness. So that's one distinction. Irritable mood is very important. And very often these will be young children who will have rage episodes. And the rage episodes are less common in adolescence. So that's another thing to keep in mind.
That's helpful.
Yeah. Another thing that we see in the younger group compared to the adolescent group is that where all these pieces are falling together, i.e. the positive family history, the sleep disturbance, the rage episodes, very often these children will present with anxiety. So the mood symptoms may not be apparent until adolescence. Anxiety and hyperactivity and impulsivity, what often looks like ADHD and anxiety, may be some of the earliest signals that you see in the prepubertal children, which change over time as far as the adolescents are concerned, where the more typical mood symptoms start to emerge.
I see. Sometimes ADHD and bipolar disorder are presented as an either-or, but it sounds like they can coexist. You can have both.
Definitely. They often coexist. Sometimes it is a symptom overlap, that there are many symptoms that are common to both conditions.
Mm-hmm.
And sometimes it is a true comorbidity. So
Mm-hmm.
true comorbidity, as you know, Andy, is described as when the two diagnoses coexist.
Mm-hmm.
So what generally the literature suggests is that you don't want to count the symptoms twice.
Mm-hmm.
And you also want to look for the symptoms of ADHD when somebody has become euthymic, because that will give you a signal, whether it was just a symptom overlap, the symptoms closely resemble, or whether there was a true comorbidity going on here.
That makes sense. I'm wondering, we've talked a little bit about manic symptoms. How do you distinguish mania versus hypomania in the pediatric population? I have a sense of how to do that with adults, but how would you do that in the pediatric population?
I think it's probably accurate to say that true mania is less common
Mm-hmm.
in the pediatric population. And what we
Mm-hmm.
see is usually hypomania.
Mm-hmm.
So a manic would be more severe, more likely to get hospitalized.
Mm-hmm.
These children may not be sleeping or sleeping very little.
Mm-hmm.
Their rage may be completely out of control. They might be causing enormous damage to property and injuring other people.
Yeah.
And all of these symptoms would be quite attenuated in a hypomanic patient. So I think it's a matter of severity, where you would see multiple symptoms in a manic patient and less severe and fewer symptoms in a hypomanic patient.
Okay, that's very helpful. Now, I want to talk a little bit about something that is often referred to as mixed depression, but that's not really the correct DSM terminology. The DSM terminology would be, of course, I guess, depression with mixed features.
Yes.
Can we first define what we're talking about? What do we mean by mixed features or mixed depression?
So mixed depression is not a very well-defined entity, but
Mm-hmm.
it's often mentioned in the literature.
Mm-hmm.
And I think we definitely see it in clinical care as well.
Mm-hmm.
So it's usually depression which has several symptoms that are considered as category B in DSM-5.
Mm-hmm.
So these might be individuals who are depressed, but also have a very significant distractibility, hyperactivity, or
Mm-hmm.
inflated self-esteem.
Mm-hmm.
So it's a mixture of the two conditions. So some symptoms of depression mixed with some features of what would be considered as even hypomania.
And what are some of the reasons that mixed depression is misdiagnosed as unipolar depression, especially in the pediatric population?
I think one of the reasons is that depression itself is a much more common condition. I think clinicians are often more comfortable diagnosing, recognizing, and treating depression. And unless you look for those symptoms of hypomania, they may not be apparent at first glance. So I think that those are some of the reasons.
I was also trained that unipolar depression in children often shows up with irritability. And so it would be, irritability doesn't distinguish the two very well, does it?
Yes, that is a problem with irritability in general, that irritability crosses so many diagnostic categories that by itself, it doesn't have a very high specificity. And that's true. You're absolutely right that irritability can be a feature of unipolar depression as well. So that's another source of confusion.
But maybe the major issue here is, as you said, if the predominant condition looks like depression, people don't ask about concurrent manic or hypomanic symptoms. They just assume the patient's depressed.
Exactly, yes.
So I guess the key here then is to have an index of suspicion, especially in a child that has a family history, either of bipolar or I guess of strong mood disorder, a lot of relatives with mood instability.
I think definitely if there's positive family history, you really want to have your antenna up for a bipolar illness.
Mm-hmm.
But severity of illness, very early onset, early history of sleep disturbance. So clinical features should also put you on alert. Be asking for really in-depth questions.
Yeah, and as with adults, I guess if they're not sleeping much, the question is, do they miss the sleep or are they tired all the time? because the quality of the hypomania or mania is that they don't sleep, but they're not missing it. They have tons of energy.
Exactly. And sleep, again, by itself is not a very reliable question, because you can have reduced sleep, reduced need for sleep in a manic or a hypomanic child, whereas in a bipolar youth who has depression, there may be prolonged sleep. So that can also throw off a clinician.
I see. Okay. Let's shift gears. We've talked a lot about how to recognize and maybe make the diagnosis. I guess one last thing, are there any tools or instruments or rating scales that might be helpful?
I think the important thing to keep in mind is that instruments that measure sort of global psychopathology, like CBCL or Eppenbach, they are not particularly diagnostic or specific enough to make the diagnosis.
Yeah.
So a good clinical history is paramount. A young mania rating scale has been used. There are also depression rating scales that can be helpful, such as the CDRS during the depressed phase.
That's the Child Depression Rating Scale.
Yeah, Children's Depression Rating Scale revised. So those are the commonly used instruments.
But I like what you said. I mean, really, it comes down to a good clinical evaluation, taking into account things like family history and collateral sources of information.
Definitely, yes.
Okay. All right, let's shift gears now and talk about treatment. Let's start out with talking about what treatments are available. Maybe let's start with which treatments are FDA approved for bipolar depression specifically, and maybe effective for mixed depression as well in the pediatric population.
So I think it's a good idea to think of the treatment of bipolar illness in terms of how do you treat pharmacologically mania and hypomania? How do you treat, say, a bipolar depression, which may often be a mixed depression, and then also to think of maintenance treatment. So the bipolar depression, which is often has a mixed quality, there is a combination of fluoxetine and olanzapine, which is approved for age 10 to 17 years old. There is also lorazepam, which is approved for ages 10 to 17 years old.
And lorazidone's more recently approved, right?
Yes, it is probably the most recently one that was approved, I believe, in 2016. Not all that recent. And there is quetiapine, probably not very impressive findings, but clinically still used. And then there is, in open trials, lamotrigine has been also found to be useful.
Interesting. That's the same with adults for lamotrigine. Obviously, it's not FDA approved for bipolar depression acutely, but there is some evidence of efficacy. And that's a rather low toxicity medication.
That's true. I also want to add that one kind of general rule of thumb when one is treating bipolar depression or mixed states is that monotherapy with an antidepressant is not a good idea.
Yeah.
So that's something important to keep in mind.
Same with adults.
Yes.
Certainly true. You mentioned lorazepam and the olanzapine fluoxetine combination and quetiapine. My experience, and please tell me if I'm wrong, but my experience is children tend to be more sensitive to weight gain than adults, especially with the atypical antipsychotics.
You're absolutely right, Andy. It's a huge problem. That weight gain tends to be a big problem. And even among children, there seem to be some who are extraordinarily sensitive to the weight gain and metabolic side effects. So that is a problem, that although second-generation antipsychotic agents have a very useful role in the treatment of this patient group, but weight gain and metabolic side effects are problematic.
Yeah. So lorazepam then is attractive because it tends to have less risk of weight gain.
Weight gain, correct. Yeah. Yes. That is an advantage of lorazepam.
All right, let's shift gears then and talk about mania and treatments for mania. Which ones are FDA approved at this point?
So second-generation antipsychotic agents are generally considered the most effective and first line. And the ones that are FDA approved are risperidone. I think that was the first one to be approved. Then there is aripiprazole, quetiapine, olanzapine, and also
Asenapine, I believe, as well.
Asenapine, yes, that's approved as well, yes.
How about our old friend lithium?
Yes, lithium is also FDA approved and for age 12 upwards. So that's another agent. And as you know, that lithium also has a role in the management of maintenance treatment. So it's a very
Mm-hmm.
useful
Mm-hmm.
agent found to treat both the acute illness and also possibly reduce relapses. So definitely a good agent to have in your range of medications that you would use.
Certainly, either by itself or in combination with an atypical antipsychotic, I would assume.
Yes.
And so, what are your thoughts about maintenance then, if we'll talk about the third area you mentioned?
So for maintenance treatment, I think our choices are lithium, which we just mentioned is likely to prevent relapses. It has been shown to be useful in monotherapy as well. Aripiprazole is a useful agent to reduce relapse. Lamotrigine has also been found to be very helpful. And then
Yes.
azathioprine is another one. And there was a 2016 study, which was a 50-week trial, which found it to be very helpful in the age 10 to 17 years with a significant reduction in the Young Mania Rating Scale. So that's
That was azathioprine,
definitely
you said.
azathioprine, yes.
Yes, interesting. My understanding, too, the azathioprine trials for pediatric mania allowed kids who were taking stimulants for ADHD.
I believe so. Yeah, they were taking stimulants for ADHD medication, and I don't believe that there were any adverse side effects.
Yeah, that's my understanding, too. They actually did just as well as the kids who were not taking stimulants. There's a lot of fear out there of using stimulants in people with bipolar disorder in general. And yet there's a lot of evidence now suggesting that as long as they're adequately mood stabilized, you're okay. Is that kind of your sense of the field?
Yes, Andy, I agree that generally the principle here is that when you're managing somebody with bipolar disorder, you want to stabilize the mood first.
Mm-hmm.
And then whatever the comorbidity is, which will also, once you've treated the mood, you have a better idea of how bad the other symptoms are or how severe the other symptoms are to treat the comorbidities such as ADHD.
I see.
So these patients actually benefit from treating the comorbidity. And if it's ADHD, adding a small or a medium dose of a stimulant medication can be very helpful.
And I would assume atomoxetine is reasonable to use as well.
Certainly, I think that's a choice too that one might consider.
Okay. How about for comorbid anxiety? Is that a situation where you might consider an SSRI, or are there other medications for anxiety that you like to use?
So I think you want to look at what kind of anxiety is it? Is it generalized anxiety disorder?
Mm-hmm.
Is there another kind of anxiety disorder such as OCD? As you know, Andy, that there is a comorbidity between early onset bipolar disorder and OCD as well.
Yes.
Or is it PTSD? The hope in a perfect world is that you would treat the main syndrome and everything else will get treated, but it doesn't always work out like that.
Mm-hmm.
If the anxiety is mild to moderate, you might just want to maximize psychotherapy.
Mm-hmm.
Maybe if it's an OCD-like picture, you might even use ERP, exposure and response prevention.
Mm-hmm.
In some cases, adding a relatively smaller dose of an SSRI might be helpful.
Mm-hmm.
And then some agents, such as lamotrigine, seem to have some anti-anxiety benefit. So that might be another agent that might have usefulness there.
Yeah, lamotrigine plays well with others also. So that would be another one you could combine with an atypical antipsychotic and has low risk of weight gain, for instance, not terribly sedating.
True.
That
Yeah,
certainly
good side effect profile.
That certainly makes sense. PTSD is something you've mentioned, and in my experience, PTSD is something that is, again, overlooked. It's not asked about or inquired about once a bipolar diagnosis is made. How does that affect your thinking about treatment and management if you have comorbid PTSD?
You want to think of trauma itself having a role in the pathogenesis, so to speak, of bipolar illness.
Mm-hmm.
That in addition to the familial contribution or the genetic risk, they can be epigenetic factors such as trauma that contribute to the onset of bipolar illness. And some of these patients who have experienced trauma might develop PTSD. So you may wish to treat that PTSD with agents that have an anti-anxiety effect. You might also consider using some alpha agonists might be helpful, where there is sleep disturbance or nightmares. Yeah, I think that PTSD and trauma are often overlooked. Sometimes they're overlooked, and sometimes they might be a distraction. That is, somebody who has a bipolar disorder, along with trauma-related symptoms, the focus might be entirely on one or the other. So I think it's a good idea to think of the conditions as, or the person, in a more global manner, to keep the comorbidity in perspective.
Now, you mentioned various forms of therapy. What are some of the therapies that have been shown to be effective for bipolar disorder in children?
So family-focused therapy has been found to be quite useful, where it has clearly a parent education component that can be very helpful. Interpersonal therapy can be useful. Then there might be psychotherapy modalities where you're targeting individual symptoms. I had mentioned ERP in somebody who has OCD. But I think if you think of bipolar illness, especially early onset bipolar illness, probably family-focused therapy has been found to be really useful, along with a strong psychoeducation component.
That certainly makes sense. Now, I'm going to pick your brain here a little bit. In the past year or two, have there been any studies that have really stuck with you? What is some of the memorable research that's come out recently to keep our audience up to date with some of the newer findings?
I have been most impressed with the high-risk data, that there is the bipolar child or the bipolar youth. But before that, there is also a high-risk individual, an individual who has a positive family history and who has some very early symptoms which can be so easily mistaken. So I found that work really fascinating and exciting. It's also an opportunity for early intervention, that maybe if we have that perspective and if clinicians are comfortable with that body of knowledge, it would help us as a discipline to identify these individuals before they actually become patients. So I think that's very exciting work.
So how would you intervene at that point? Would that be psychosocial interventions? Would you consider medication even if it's that very early stage?
So I think I would look at it from various viewpoints. So I think that pharmacology-wise, I would be very cautious about medications with this patient group. There might be instances when you may have to use the medication, but I think very careful attention should be given to, does the patient really need an SSRI for their anxiety? Or does this patient really need a stimulant for their hyperactivity and inattention? So I think that there should be really in-depth attention to pharmacology. I think psychoeducation can be very useful. Again, doing family-focused work and psychoeducation and teaching the child mindfulness if they are old enough to learn that. I think that would be very helpful. And there are supplements which haven't shown great outcomes, but there might be instances where you want to avoid any medications and think of supplements.
Well, fish oil is one that comes to mind.
Yes, exactly. I was thinking of fish oil.
There's been quite a controversy over the past few years of the use of atypical antipsychotics in children and adolescents. But yet, you have to think about the risk-benefit ratio, and sometimes there's a risk of not treating. Is that correct?
Exactly, yeah.
How would you advise clinicians to think about using atypical antipsychotics and when to use them appropriately?
If I may just digress a little bit over here and also add, so Andy, I think that it's no secret that the DMDD diagnosis in DSM-5, it may not be the entire reason, but one of the reasons why this concept was incorporated in DSM-5 was that there was worry that perhaps there was overdiagnosis of bipolar disorder, and thereby there was an overuse of antipsychotic agents. But you're absolutely right. It's important to accurately label and accurately treat. And these are very important medications. And in many instances, they improve the quality of life and improve long-term outcome. So as far as safe and as a responsible clinician, you want to use a medication that has the least side effects, monitor very closely, be extremely attentive to weight gain and metabolic side effects.
Yes.
If there are any cardiovascular risks, as we know that individuals with bipolar illness are also at baseline at risk for long-term obesity and cardiovascular disease.
Yes.
And when you add in that mix, you add an antipsychotic agent, you want to be doubly attentive to those outcomes.
Also, prolactin elevation, especially in females.
Prolactin elevation, that has been a problem. And then gynecomastia. As you know, Andy, a few years ago, there was a lot of talk about gynecomastia associated with antipsychotic agents. So you want to be attentive to all of those agents and use them when it's needed, but be very mindful of monitoring and long-term side effects.
That's extremely helpful, and I think that might be a very good place for us to wrap up. I want to thank you very much. This has been a fascinating discussion. Is there anything else that you'd like to add? Anything else you feel like we maybe didn't emphasize enough?
I thank you so much, Andy. It's been a pleasure talking to you. Really a most enjoyable discussion. I think the only thing that I would add is maybe some attention to stigma that I think we often forget, that there is stigma attached to major psychiatric disorders. And I think as clinicians, we need to overcome that and recognize the importance of accurate labeling. So I think that I would probably end with these final words.
You're so right, especially when we're talking about children. It brings out something paternalistic and maternalistic in all of us when we talk about children. So I think you're really onto something.
Yeah.
And I think you're right when you talked about the DMDD, is there were politics, I think, around that. And we have to put ourselves back into the mindset at that time. Late 2000s, early 2010s, there was a lot of concern about the use of overdiagnosing bipolar and using the atypical antipsychotics. And hopefully now we've come to a more balanced and nuanced place.
Right.
Yeah. With that, I would like to wrap this up and say thank you all very much for your attention to this podcast. I want to thank Dr. Ghaziuddin very much for your time coming to us from Michigan. And I want to thank you, the audience. Please don't forget to answer the post-test questions, and please try to visit us for more of our podcasts. And you can find out more information about NEI at our website, which is www.neiglobal.com. And this is Dr. Andy Cutler saying thank you so much.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.